Okay, so now we're going to start in on the second part of your evidence-based practice, quality improvement, informatics, safety, and legal issues lecture. Your learning outcomes for this lecture are that you will be able to discuss the components of the North Carolina Nursing Practice Act, verbalize the legal responsibilities of nurses in professional practice, identify 4 specific areas of the Health Insurance Portability and Accountability Act of 1996 and their impact on nursing practice, discuss the legal requirements of the Patient Self-Determination Act of 1991 and nursing's responsibilities, and describe the nurse's obligation to report practices that endanger the health and safety of patients. We have talked about it in several lectures, but we're going to visit it once again. The North Carolina Nurse Practice Act. This is your go-to, your need to know, your rules of the land on what you can and cannot do as a nurse, as a registered nurse in North Carolina. If you have not familiarized yourself with it, I would strongly encourage you to do so. All you have to do is go to the North Carolina Board of Nursing website, go to Practice and click on Registered Nurse, and then you will find laws and rules, and the first one says Registered Nurse Law, and that is your Nursing Practice Act. In that Nursing Practice Act, it describes what components make up the practice of a registered nurse, including assessing the patient's physical and mental health, recording and reporting the results of the nursing assessment, planning, initiating, delivering, and evaluating appropriate nursing acts, teaching, assigning, delegating to, or supervising other personnel, and implementing the treatment regimen, collaborating with other healthcare providers in determining the appropriate health care for a patient, but subject to the provisions of GS 90-18.2, not prescribing a medical treatment regimen or making medical diagnoses except under supervision of a licensed physician, implementing the treatment and pharmaceutical regimen prescribed by any person authorized by state law, providing teaching and counseling about the patient's health, reporting and recording the plan for care, nursing care given, and the patient's response to that care, supervising, teaching, and evaluating those who perform or are preparing to perform nursing functions and administering nursing programs and nursing services, providing for the maintenance of safe and effective nursing care, whether rendered directly or indirectly. You'll notice in the practice of nursing by a registered nurse compared to that of a licensed practical nurse, that in the registered nurse's components, it includes assessing, and it includes teaching, and it includes delegating. You won't see those same components without some additional descriptive factor in the licensed practical nurses components. For instance, they participate in the assessment. They can assign or delegate interventions to other qualified personnel under the supervision of a registered nurse. They can participate in the teaching and counseling. So that's where you're going to see the differences. Also in the Nurse Practice Act, it goes on to explain about officers to the Board of Nursing, their duties, powers, meetings. It has additional findings like nurses registered under previous law. For instance, it says on June 30th, 1981, any nurse who holds a license to practice nursing as a registered nurse or licensed practical nurse shall be deemed to be licensed under the provisions of this article. So it's got additional articles from way back, forever and a day. So it's a lot of information, but it really, the key part that you should take away is the components of what you as a registered nurse are able to do, and as a licensed practical nurse, what they can be expected to do, so that you know how to delegate appropriately, because you are expected to follow that. You're also expected legally to advocate on behalf of your patient, protect your patient's rights, and make sure that they understand those rights. Provide care, again, within your scope of practice. Discern responsibilities of nursing in relation to those of other disciplines. Provide care based on standards of care, and shield oneself from liability. Legal issues, some terminology and that you need to be aware of involve torts. So there's intentional torts, quasi-intentional torts, and unintentional torts. Intentional torts would include assault, battery, and false imprisonment. Intentional tort, assault would be exactly what it sounds like. It's when one person makes another person scared or apprehensive through a threat. Battery is the intentional and wrongful physical contact with a person that involves injury or offensive contact, such as restraining a client and administering treatment without that client's consent. False imprisonment would be restraining a competent individual against their will who is not a risk to themselves or others. So those are all examples of intentional tort. Quasi-intentional tort would be a breach of privacy, defamation of character, which is the false communication with disregard for truth or a person's reputation, whether it be libel with written word or slander with verbal word. And then unintentional tort, which is negligence, practice or misconduct that does not meet the expected standards of care and puts the client at risk for injury. Those would be the unintentional tort, is your negligence and malpractice. The Patient Self-Determination Act of 1991 stated that all clients must be informed of their right to accept or refuse care. So clients do have a right to refuse care. They must indicate that they are refusing care by signing a document stating that they understand the risk of refusing the proposed care or treatment. The nurse has a responsibility to notify the provider that the patient is leaving and also to discuss risk with the patient prior to the patient leaving if they're able to do so. And then the nurse is responsible for documenting the information provided and that the provider was notified. The goal was for the patient who refuses treatment to sign an AMA form. Again, that is when that is possible. Sometimes if they just walk out and they refuse to sign it, I mean, you can't force them to sign it, but that's the goal, is to have them sign that form indicating that they understand that they're refusing treatment and they are assuming the risk associated with such. If the client refuses to sign that AMA form, then the nurse needs to document that as well, along with the notification of the event to the provider. Here is your North Carolina Board of Nursing Nurse Practice Act. I tried to summarize it for you, but really it would just do you justice just to go and print it off for yourself. Professional liability issues. There's always going to be issues regarding social media and social networking. There's always going to be issues regarding HIPAA, unfortunately, and maintaining people's privacy, not feeling like you need to talk about patients' care on the elevator or in the cafeteria, or going home and telling your neighbor who is a mutual friend of a patient. Sometimes it happens innocently and sometimes it happens not so innocently, but you have to protect the patient's right to privacy. The registered nurse has 3 professional liabilities that are of particular concern, which again are professional practice conduct, adherence to the principles of delegation established by the American Nurses Association and the state's Nurse Practice Act, and then accurate and timely documentation. In all patient situations, it's extremely important that nurses recognize their authority and take intentional steps to avoid misconduct. Nursing students and nurses alike must understand their professional obligations associated with sharing online information. Nurses must be alert to the potential for violating professional conduct standards in all patient care situations and act intentionally to avoid breaking the law or the code of ethics for nursing. And nurses who engage in professional misconduct are subject to legal and disciplinary action in their state or jurisdiction. Substance use disorder is another challenging issue for the nursing profession. Substance use disorder encompasses a pattern of behaviors that range from misuse to dependency or addiction, whether it is alcohol, legal drugs, or illegal drugs. And that comes from the National Council of the State Boards of Nursing in 2014. Nurses have an ethical and legal responsibility to report colleagues suspected of alcohol or drug abuse. And with regards to social media, inappropriate use of social media can result in breach of client confidentiality. Avoid disclosing information online. Use caution when discussing clients' care over the phone. Avoid posting inappropriate comments about work colleagues, patients, etc., and report any social media violations to the nurse supervisor. In regards to appropriate delegation, registered nurses must appropriately delegate to licensed practical nurses in a manner that will ensure patient safety and meet nursing standards of care. All nurses should be familiar with and adhere to the specific state or jurisdictional requirements for delegation to prevent patient injury and legal action. And then in respect to documentation, nurses are required to document patient information in written or electronic format. This documentation becomes the legal record of care provided by the nurse. Falsification of patient records is unethical and illegal. Documentation errors include omitting documentation from patient records, recording assessment findings obtained by another nurse or unlicensed assistive personnel, and recording care that you have not yet provided. This one is so common in, unfortunately, like you can't say you're going to go do an assessment and turn your patient and chart that before you actually do it. That is not appropriate. The documentation of assessment data in a timely manner allows other healthcare professionals to accurately address a patient's concerns or change in status. Nurses also have a right in regards to patients' informed consent. As the nurse, you are not to provide that informed consent, but you are to witness that informed consent, verifying that the patient has received and given consent for the proposed treatment, that they have been given the risk and benefits of the proposed treatment by their provider. You're witnessing their signature, but you are not giving that information. Also, when in regards to organ donation, advance directives, and DNR orders, the nurses need to be aware of your responsibilities regarding such and should always be familiar with your facilities policies. Organ donation, a lot of times what I've seen is that you will call and notify the organ donor agency of the patient and of the patient's demise, and they will make the determination of whether that is an appropriate candidate for organ donation or not. And that probably varies with adults. That's just how we did it with the babies. So let's say I had a baby deliver that was 22 weeks, and technically, things eyes were fused or what have you. I still didn't make the decision. I had to call the organ donation agency, and they would say, yes, that's an appropriate candidate. We'll talk to the family, or no, that candidate's not appropriate. So I would expect that was similar for an adult patient, depending on, I guess, their organ donor status. Informed consent for minors, except in the case of emancipated or married minors, must be obtained from the minor's parents or legal guardians. Patients who are mentally incompetent or are under the influence of alcohol or drugs are not legally permitted to give informed consent because of their inability to comprehend the required information, and instead must be obtained from a legal guardian, power of attorney, or healthcare proxy. Acting as a patient advocate, the nurse is responsible for ensuring that the patient has received adequate information regarding the proposed procedure, understands the content of the informed consent form, and was not coerced into giving informed consent. The nurse must be concerned with the legal implications of a patient's ability to read the informed consent document and the patient's cultural beliefs regarding decision making. In regards to the Patient's Bill of Rights, I said 1991 in the prior slide because that's what it said somewhere, but now this is referring to 1992. At any rate, it's in the early 90s that the Patient's Bill of Rights was formulated, and that was done so to inform consumers about their specific privileges of which they should be aware. And so every patient gets that information that informs them that they should expect high quality hospital care, a clean and safe environment, involvement in their care, protection of their privacy, help when leaving the hospital, and help with their billing claims. I'm just reading through about organ donation. I already talked to y'all about that. And then advanced directives. Advanced directives consist of 3 documents. So your living will, durable power of attorney, and healthcare proxy, commonly referred to as durable power of attorney for healthcare. A living will specifies the treatment that a person wants to receive when he or she is unconscious or no longer capable of making decisions independently. A durable power of attorney is a legal document that allows a designated person to make legal decisions on behalf of an individual unable or not permitted to make legal decisions independently. And the specific durable power of attorney for medical care is called a health care proxy. DNR orders, or do not resuscitate orders, are written documents that indicate the extent of resuscitation efforts preferred by a patient or a legally designated family member in the case of cardiac or respiratory arrest. Nurses need to become familiar with their state statutes and healthcare institutions' policies to ensure that you are compliant with the DNR orders. HIPAA, which stands for the Health Insurance Portability and Accountability Act, focuses on 4 areas involving privacy of health data, security of health data, notification of health data breaches, and the right to get copies of healthcare data. HIPAA serves to protect the confidentiality of a patient's healthcare information. It gives the client the authority to control the release of their health information. You'll notice a lot of times you have to sign a release of information if you're needing results from an x-ray and you need to take them to a different provider. Sometimes they'll ask you to sign a release of information. Clients have a right to obtain their medical record and to also submit requests to amend erroneous information. So let's say that you went to the doctor and you had a urinalysis performed, and unbeknownst to you, they did a urine drug screen for whatever reason, and it came back positive, but you don't agree with that, and you want to make an amendment to your health records to state such, then you can do that. You have a right to amend that erroneous information and state that not only were you not aware that you were having a drug screen, but that you dispute the allegations that are being made. Also, the HIPAA sounds like a dance or something. HIPAA requires providers to notify their patients about how their medical information is used and shared with other agencies. So that's that nice photocopy pamphlet that you get at every doctor when you go and register, and they give it to you, and it has all that nice information in there. HIPAA also affords clients the right to make sure that their records are only accessed by those with a need to know, and that their records are kept secure. Electronic medical records should be password protected, and it's our responsibility as nurses to avoid leaving patients' medical records in view of others that do not have a need to know. We should keep them secure. We should not copy them except in the case of transfer among hospitals or between providers. And you should really treat their information like you would want your information treated. Safety. For your learning outcomes regarding safety, it's expected that you will provide patient care in a manner that ensures protection from harm and injury for both the patient and nurse, incorporates national patient safety goals into the plan of care to ensure patient safety, implement safety principles such as standard precautions into the provision of patient care, and utilize the occurrence and variance process to report medical errors in a timely fashion. In the previous part 1, I mentioned QSIN, which plays a significant role in promoting quality care for patients. They also focus on safety with their initiatives. Initiatives for QSIN include safety and quality competencies that target areas like safe use of equipment, accident and injury prevention, home safety, ergonomic principles, evidence-based practice, and informatics. And as a nurse, of course, we want to kind of emulate that do no harm that you often hear the Hippocratic Oath for providers, but we also want to model that, and we don't want to cause our patients any harm. We're there to help them and to help them heal, but we do know again that we're human and that a lot of times there's breakdown of communication, miscommunication, and so that is a significant factor in the majority of sentinel events, especially. Again, sentinel events are those events that result in unexpected death or major injury, or situations where there is a direct risk of either of those. And I touched on that earlier. Some other examples that I didn't mention in the earlier presentation include hemolytic transfusion reaction, infant abduction, or discharge to the wrong family. This was a kind of a neat little printout. You could actually print it out and keep it in your pocket at clinical, you laminate it or whatever. But I got this off of a website that I put in the references, but it has safety, and it has S safety. Verify the patient's name, date of birth, allergies with their ID bands, side rails up ×2, is their bed in low position, wheels locked, and call bell within reach. For assessment, for A, making sure you're checking their A, B, C, Ds, their airway, breathing, circulation, dressing, drainage, and their neurological status. Assessing their fall risk. Do they have on non-skid socks? Do they have their fall bracelet on? Are their fall precaution signs up in place? Assessing equipment. Is there any tubing that could potentially cause a hazard? Or how is their oxygen set up? Is there any risk for the oxygen in use, like is the patient smoking in the bathroom? T for teach, so communication board to let them know about their staffing for the day, their activity restrictions and reorientation. And then Y for you, do you have everything you need to be safe? Again, here is a separate handy little grid about infection control from the CDC that you see below. In infection control, we want to focus on precautions. So contact precautions, droplet precautions, airborne precautions, and what that entails. So for contact precautions, what is required? We know that C. diff would require a patient to be on contact precautions and would require the nurse to have gloves and gown. The patient should be in a private room and have limited transportation and movement, use disposable equipment, and that room should have a priority when it comes to being disinfected. Droplets, they travel about 3 feet when a patient talks, sneezes, or coughs. So influenza, pertussis, mumps, COVID. We want to have a mask and standard precautions, patient to be in a private room, limit transportation. And then your airborne precautions, which are germs so small that they float in the air and travel long distances. So you would require an N95 mask in a negative air pressured room. Again, limited transportation and movement. So keeping everybody safe by implementing those infection control precautions. Other responsibilities of the nurse include the use of equipment safely, making sure that you're familiar with that piece of equipment, that you're comfortable using it, preventing patient falls, safe use and disposal of hazardous materials like chemotherapy be agents, preventing the seizing patient from harm, safe use of restraints and seclusion, promoting safety in the client's home, fire safety, and safety across the lifespan. So the use of equipment, we want to make sure that we're competent whenever we're using equipment, that we've been educated on that piece of equipment, that we feel comfortable using it, and that we use it in the correct manner for which it was intended. Being able to properly set that equipment up. We want to make sure we reduce any risk of electrical shock by using the appropriate designated electrical outlets, especially for life-saving equipment. You'll notice they have like red outlets in the hospital that are designated for those pieces of equipment, because if the power goes out, they are run by a separate generator. We also want to make sure we unplug equipment before cleaning it, and prevent any kind of overdosing of medications by using IV pumps and PCA pumps as they are intended, and by programming them correctly and with a witness when indicated. And of course, having equipment regularly inspected by maintenance. Falls. We always need to make sure that we're screening our patients for any potential fall risk. If they are at an elevated fall risk, we want to move them closer to the nurse's station. We want to make sure that their canes, walkers, or whatever other assistive devices they have are within reach, and that they know how to use them. It's not doing any good if they don't know how to use those. Keeping their bed in a low position. So if you've raised the bed for assessment, making sure you put it back down in the low position. Preventing all the side rails from being kept up, so there should only be 2 side rails up. Keeping the wheels locked on any device that has wheels. Using bed alarms and sensors if the patient is at risk. And making sure again that all their items of need are within reach. They have a call bell, they've been up to the bathroom. Patients who have cognitive dysfunction or have had medications that may impair their judgment, those patients are especially at risk, as well as patients who have any type of balance problems, orthopedic problems, generalized weakness, poor vision, that type of thing. And then with seizure patients, patients who are at risk for seizures or have had a seizure should be put under seizure precautions. So low stimulation, decreased lighting, padded side rails, up ×2, having appropriate oxygen and suction and IV access, making sure that's all in place and accessible, and a room close to the nurse's station, and educating the client and their family on the precautions. And then with seclusion and restraints, there are many agency policies and federal state laws regarding seclusion and restraints. So you have to know those if you work in the area that uses seclusion and restraints. You want to use them for the shortest time necessary. You don't want to use them as a first intervention. You want to use them as a last resort. We used to have boxes on various units for alternatives to restraints. Had to undergo yearly competency training on restraint usage, and being aware that restraints are not, you can't just have them as an as-needed order. They have to be ordered by the provider after the patient's been assessed face-to-face, and then there should be a certain designated time frame for that restraint to be in use. The order must include the reason, the type, the location, period of time for the restraint, and the type of behaviors that warrant that use of the restraint or seclusion. That patient needs to be assessed frequently per hospital policy, and make sure that patient still has range of motion. You can fit 2 fingers between, if it's like whatever type of restraint it is, that you can fit 2 fingers between the restraint and the patient's skin, and that you never leave the patient alone unrestrained. Additional safety issues include fire safety, home safety, safety across the lifespan, and safe use of oxygen in the home. So remember, with fire safety, if you were to see a fire, you'd want to do pass, right? You'd want to retrieve the fire extinguisher, pull, aim, squeeze, and sweep. You want to assess any client who's at risk for injury based on their age and their developmental status, their mobility, balance, cognition, and sensory awareness, what the environment is like, their community, and medical and pharmacological status. For instance, if you have an infant, you would want to keep small objects out of their reach and not place the infant in a supine position. But an older adult would require you to remove items that could cause them to trip, like a throw rug, and to make sure they have adequate lighting. And so safety issues are going to be specific to that patient's developmental age and status. The nurse should first assess any individual who has suffered an injury, whether it be a patient or a visitor, and perform any needed treatment ordered by the provider first before completing the incident report. So don't delay treatment to complete an incident report, but after the patient or visitor has been assessed and treatment's been rendered, then an incident report should be completed and should be filed by the person who identifies the unexpected event has occurred. So it might not always be the person who's most directly involved. Usually it's going to be your charge nurse, clinical leader. It's to be kept confidential, not shared with the client, and should not be a part of the medical record. It is forwarded to risk management for process improvement and should include all pertinent information about the affected individuals. And it should be completed within 24 hours of the incident. Examples that would require an incident report include a needle stick injury, a client or visitor fall, procedure error, loss of property, threats made to staff or patients, medication errors, or equipment-related injuries. National patient safety goals is something that you will see throughout the rest of your program, and I've asked for you to start looking at those with some of your clinical paperwork. You could go to this link to retrieve some information about the National Patient Safety Goals, but just a short summary are that patients are identified correctly, improved staff communication, use of medication safely, use of alarms safely, prevent infection, identify patient safety risks, and prevent mistakes in surgery. As a nurse, you are obligated to report any signs or symptoms of a coworker who is suspected of alcohol or substance abuse while they're working. So they smell of alcohol, they have frequent need to have mouthwash, for instance. I mean, I'm not trying to laugh, but I just was envisioning somebody walking around with mouthwash in their hand. Bloodshot eyes, mood swings, excessive sick leave, excessive tardiness, frequently forgetting to have a witness for narcotics when they're needing to be co-signed. Numerous complaints about patients reporting that they haven't received pain medicine from that particular nurse, even though the nurse is saying that she's administered it or he's administered it. Preferring or demanding to work night shift when there's less supervision. Frequent requests to leave the unit for breaks. Nurses also have an obligation to report physical abuse that they see or reports of emotional abuse, obligation to report communicable diseases such as tuberculosis or foodborne illnesses such as hepatitis A, and obligation to answer questions regarding organ donation process and providing emotional support. There's the resources used for this lecture, and that will bring us to an end for week 4's lectures.